everyone in sunny Australia. Well, good evening in Australia. I'm sure you all had a nice hard day at work and having a cold beer or so. And what we're going to do today is we're going to talk about the basics of regeneration and ethos to start off with, and how we feel it's important to have true bone. And then I'll go on to showing more usages in sinus augmentation and the restoration of the posterior ridge. I'd like to thank W9 Medical, obviously, for arranging this, and also I've just got to come down sometime to come see my brother-in-law who's in Vaucluse, and my brother who lives in Brisbane, who shoots for Australia. Right, let's just change it. Sorry, we're just having a little technical difficulty here. Yeah. Okay, so a bit about me. I've been placing implants since 1991. My mentor was Barry Edwards, the legendary Australian in London, who invented the internal hex and was possibly the first person to use angle abutment. So I saw him the other day, and he's still healthy at 76, 77 now. And it's something for Australia to be proud of. He was absolutely an innovator when it came to doing. And as far as sinus augmentation, I remember him showing me cases in 1986 and 1987 of augmentation, and he taught me to do my first case, and I think it was about 92 or 93. And I remember as I started, it basically, he sort of showed me the basics, and then he sort of said, "Oh, I see you can understand. I'm sure you'll be fine." And he went across the road to a pub, so that was good Australian teaching. Anyway, so as I said, I've been practicing here in London for in dental implants since 91, in the same room, same surgery. So I end up, it's a good opportunity to see the follow-up that we can actually get long term, and especially with sinuses. And I've been amazed how predictable the outcome with sinuses are. So this is why I prefer my route to restoring the resolved posterior maxilla. Right. You know, essentially when it comes to materials, it's a bit like when I'm looking at my favorite things, which are cars, and I love Porsches. And when I looked around, and, you know, a bit like Ferdinand Porsche, I just couldn't see anything that I particularly liked that would fulfill the criteria that I wanted to work in. So I decided to, like Ferdinand Porsche, building his own cars. He has me racing at Silverstone event. I decided to really look into materials, as I'd worked for a number of companies, and to develop a material that I felt would suit the regenerative ideals that I had best. It's been a long journey. I've been involved in synthetic grafts since 2003. The reason why I got into synthetic grafts was essentially, at the time I was using allografts, and in New Jersey, they had the situation where the bodies were stolen. And every patient came into me in London here sort of saying, whenever I mentioned bone graft, they said, "Oh, we don't want part of Alistair Cook," who was the famous English presenter, radio presenter, who had his body stolen. So I decided that I would rather look at this thing in a much clearer way, and use materials that A, turned over to the patient's own bone, and B, that the patient would be more comfortable having within being placed in them. So and it makes it a lot easier. So this long road led to the development of EthOss, a product which is now being launched in Australia. And the basic gist behind this is that we want to work within the parameters of host healing to regenerate the body's own bone. Okay, so rather than just packing something in and saying, "Oh, I filled the hole," or "I've restored it," we want the body's own bone. These are all the sub-distributors in Australia for your different areas. I know Australia is a big country. It's although it probably takes just as long to cross London the way traffic is by car. But these are the local distributors, so if you will know who they are and to help you find the products. All right, so today's talk is going to be essentially on the restoration of the resorbed maxilla. The reason why this is a real problem, obviously post-extraction, especially in periodontal cases, as well as sinus pneumatization, often lead to a very thin and resorbed amount of bone in the posterior maxilla. And there's two ways to restore it. There's a graftless way and by grafting. The graftless ways generally involve alveoplasties with sort of fixed immediate arch restoration, cross arch immediate restoration, say the all-on-4 approach. I find unless the patient's really old, this is a way I really prefer not to go. The moment you do a big alveoplasty, it takes 20 minutes of your time and you age the patient 20 years. So I sort of feel that if the patients are, you know, sort of late 70s, mid 70s, yeah, this gives you a great option. But all the other younger patients are always, even if they're with great difficulty, I prefer to try and restore the case. Okay, now there's also lots of other graftless techniques like zygomatics and nasalis implants are making a big show at the moment. And pterygoids, I work with a company where we do full arches, and we use pterygoids. In fact, I was first taught pterygoid implants by Barry Edwards, the Australian, right at the beginning in 91. But as we've become more, and here's a case showing sort of by sort of zygomatic, you know, cases with two zygomatics. Look, they work and they work really well, and especially on an immediate basis. But there are complications and there are difficulties in cleaning. And as I said, I always prefer, if it's an older patient, severely resorbed, yes, it's the last chance. Here's just showing planning and the drilling sequences for the placement of the zygomatics. But I always prefer to look at the grafted side. Yes, you know, a lot of people sort of say using particulates is the easy route. No, in actual fact, using particulates in regenerative dentistry is actually possibly more difficult than merely using a block or using a graftless situation. It actually takes a lot more skill and a lot more understanding of host healing. There's lots of different materials we can use. We can use autogenous. I started off using autogenous in the sinus, then I used allografts, and now I've used for the last 16, 17 years just synthetics or alloplasts. I've never really put xenografts in the sinus. My fears have always been more around the possibility of an infection and some effect really with the material being very difficult to remove afterwards. And we can use a lateral or a crystal approach, crystal or internal. And there's so many different materials and tools and a lot of new exciting things which I'll briefly touch on as well as we're going through. So when we look at the ideal particular graft, you know, these are the things we're looking at. It'd be ideal if it's osteoinductive, osteoconductive, biocompatible. Yes, biocompatibility is a big thing. You put these graft materials in, the patient's not taking a painkiller the next day, even in the sinus. Yes, we might get a little bit of swelling from the trauma of the lateral window 2-3 days later, but there's never pain, not even the next day. And I think this is due to the biocompatibility. The idea that material must be totally replaced by bone is actually another strong factor as well. Basically, this is what we want to do. This is what the patient wants, the body wants. So therefore, we need an appropriate resorption time in relation to new bone. So as new bone is being made, the graft material is resorbing, and I'll show you the research we're doing on that. Well, obviously, we've got to maintain volume stability of the graft, have satisfactory mechanical properties, and I like the idea that when you're using a bacteriostatic synthetic, there's no risk of disease transmission. In fact, I'll show you using it in infected sinuses right near the end. And these are basically Yip and Nicholas Lang and Koya. This is what they said. And the only material I saw that sort of fulfilled this criteria was beta-TCP. It's the only one that seems to fill all of them ideally. Yes, you can make highly resorbable AHAs, you know, a nano AHA, but I think that this, from all the work that I've been doing in the last 17, 18 years on synthetics and the research, this seems to show the best results. So I'm just going to show a case that's not a sinus case, just to get the concept about regeneration. And here we're just going to be grafting into an extracted socket, a wide socket, and we're going to place an implant. And what we're going to do is just basically push the implant into the graft. So there's going to be no bone to implant contact and no primary stability. And as you can see, there's a small buccal defect. This is another key: never overgraft with these materials. You just need to graft enough. As you can see, no bone to implant contact. And here we see at 10 weeks later, we see a new buccal plates regenerated. And yes, there's still graft material in there, but on all our studies, which I'll show you later, over 50% is new host bone. So you can see at 11 weeks, when this was taken after the healing collar, we had 77, which is higher than if I did that implant system in the adjacent host bone. So we get very high osteal readings, and then we end up with a good regenerative soft tissue. This is loaded at 1.5 years. And if we look through the x-ray, what we're seeing is the graft material slowly turning over. At 10 weeks, there's only 12% graft material. 12 weeks, it's loaded. And here it is at 2 years, and it will have fully turned over to graft material. The case is actually loaded over 3 years now. It's nearly 4 years. And it just gives us an idea of the principles and the core principles of using materials that actually turn over to host bone. So, when I look at it, regeneration is something that can only be done by the host. Doesn't matter how clever we are as dentists. If we remove half the liver, the body will regenerate the other half in 21 days. There's no way that we could do that with our own hands. And so, when we're actually putting other materials in, say xenografts or something, we're essentially integrating those materials into the site, and that actually reduces the amount of space for the patient's own bone. And especially in the sinus, we really want to only have the patient's own bone so we can assess it long term, and I'll go through that with you. Yes, it's good to have a scaffold, but scaffolds are just bricks. And essentially, when we're actually regenerating bone with scaffolds, say big HAs, big particles, yes, it is easier. It fills the hole easier. Yes, the x-ray looks better because, it's white. You don't know whether it's host bone or bovine bone or equine bone or porcine bone. It's because it all looks like one thing on an x-ray. So that's why I often say when people say, oh, show us the CBCT to see the result. Well, the only way to assess the success of any graft, because it's living tissue, is to actually use histology and histomorphometry. So essentially we end up like this. The cement in the wall is the patient's own bone, and the bricks are the bricks, which are the HAs, the xenografts. If we're doing it, yes, it makes it a lot easier to make the wall because you're filling it up mostly with other stuff. But does the body essentially want that, need that? So when you're using something that's fully bioabsorbed, you essentially have to make a concrete wall. So it's all bone. Now, that obviously has difficulties, and here I'm just showing you little techniques that we have used using resorbable sutures to help support, to help reduce the pressure of the soft tissue and the muscular pull, because you realize, obviously, the most important aspect is to have stability in the site for new bone formation. So I try to look at it as that we're not really doing carpentry. Yes, we have saws and we have drills and we have hammers, but success, as Horvath in his research suggested, it's not all about quantity. It's not all about having a set of calipers and saying, oh, look at all this bone. We actually need to have quality of the bone as well. This is important, especially when we're placing an implant in that site. So this is why this is a very important aspect. Quality is something we need to assess. And when we look at the research, and this is a systematic review, Homlay Wang, Homlay Chang, and we sort of see that residual particles, when we're using HAs, xenografts, lead to up to 23% less host bone, whereas with alloplast there's a 22% increase in bone graft material. And this is probably due to reduced connective tissue, but now more research and more medical research is actually showing the great osteoinductive potential, which I'm going to show you in a minute, of these materials. So what we've got to do is understand the biology of what we're doing. Rather than, let's go back to the early days of university when we understood physiology, biology, and why the host was healing. Let's understand what's happening in the bone rather than just looking at it as a mechanical, as a block of wood. And as I said, there's a lot of really high impact journals, you know, impact factor 12. There's over 200 papers researched and published on PubMed, mainly in high impact medical journals, showing the effects of calcium phosphates, angiogenesis. And this is where a lot of the development is going in bone regeneration in medicine. And this is where I picked up a lot of these ideas, is by looking what the orthopedics seem to be doing. So the key to all healing is oxygen, and oxygen is blood. And this is why I've never used a membrane in the last 16 years, because I have a stable graft which is cell occlusive. There's no need for a membrane. So we can encourage host healing, not just by bringing in blood, but also allowing the periosteum to induce stromal cell-derived factors, which lead to mesenchymal cells. So it's really important to try and get the healing as close as it is to nature as we can. Yes, we've published a lot on it. These are just papers we've published in the last 5 years. A lot is on PubMed, so if you want to just go there, Google my name, and you can pick up all the research we're doing, and if you want to read it, you can have a look. So generally, when we're using the material, we're using the simplified regeneration protocol, which I went over in the last lecture, and so we won't really go over. But the key is this is at 10 weeks, and what we're seeing here is essentially host bone, 55% new bone, and 8 to 12%, judging by, we've had a number of different studies, multi-center studies involving the US, Greece, and Germany. And the 55% new bone is the average, 50 to 55. But as I say, there are some graft particles there, but they're only about 12% of 10%. So this is the key, is that we're developing host bone. So when we look at it, it's not a question of looking at it and saying, oh, it looks like bone, or is it bone? Well, it's hard, so it must be bone. No, otherwise this little guy could easily be Batman. This is the way we find out, using histology and histomorphometry, so we can actually measure the quantities and the quantity and percentage of host bone. Okay, that's just the radiographs. And what this allows us to do is, once we actually, what we see, and if you visit EthOss case studies, you'll see it again and again. I hardly do any soft tissue surgery now, especially in a case like this where there's a shortage of buccal keratinized tissue, because we feel that if you restore the hard tissue with predominantly the patient's own bone, if a patient regenerates that tissue, the patient actually regenerates the keratinized soft tissue as well. Here, I've done no soft tissue grafting. And so we cut down the amounts of surgery. Yes, I like doing soft tissue surgery, taking stuff from the palate, but guess what? Patients don't like it as much as I do. And here's just showing the case. And that's 4 years loaded. And again, you could see on the last picture there, the 45 millimeters of new buccal bone over where that defect was. And because it's host buccal bone, that's why we have that nice looking tissue. Here's the publication. This is the basics of simplified regeneration protocols. So extraction, leave it 4 weeks, place the implant graft, load it 10 to 12 weeks. We do that routinely. Just going to go through a little bit and we'll get on to sinuses. Just basically some of the research we do. So this is 8 millimeter cortical defect, and we look at it, and that's a xenograft. Yes, it works really well. You can see it's really nice and hard. It's kept the volume, but the vast majority of that is in fact bovine bone, and there's small bits of rabbit bone in between holding it. This is autogenous. It works really well. It's the gold standard, but what do? We lose volume. So what we wanted to try and do is look at a different route. And here we have the EthOss, and again, you can see we've got a hard area, and it just looks so much more like the actual rabbit bone, because it is essentially the rabbit bone. There's over 50%, which we see in I'll show you later on in a few minutes in the histology. So we're wondering why this happens, and again, this is down to all the medical research showing the osteoinductive potential. And if you have a look at the graph, TCP appears to have the highest osteoinductive potential of the calcium phosphates. just more research. This is PNAS, which is possibly one of the most cited journals in medical research. And again, it's showing the osteoinductive potential of the materials. And this is the exciting part that we like. We've done our own studies. This is just from the pilot. We're doing the main study at the moment. And again, there was nothing. This is in the middle of muscle tissue. And again, you can see osteoid formation up against particles of EthOss. So this is an exciting thing that we're redoing the study at the moment. When we did the initial study, yes, we needed, this is micro CT at Sheffield Medical School. And when we look through, you can see the white of the particles. As we're going deeper down, the darker spots is the new host bone. And the interesting thing is the deeper we go, most of the new host bone is forming right in the center. And again, this is due to the osteoinductive potential. Whereas when we look, sorry, at the xenograft, that slide didn't work, but if we look, this is exactly the same rabbit. That's the xenograft, and that's the EthOss. And you can see the benefits of the osteoinductive effect by looking at the center of the EthOss grafted site, where there's a lot more new bone growing. So it's not a question of this growing conductively, it's growing from the center. And here's showing the difference of that exact rabbit. This is the exact histology taken. And yes, there is a little bit of bone. You can see it on where the xenograft was, but we're getting a lot more new host bone at 8 weeks. And this is why we seem to like this. Here again, when we look at the micro CT, you can see the difference in the two conceptual ideas. This again is all published recently in a medical materials magazine, so a journal. So if you want to, it's up on PubMed, and I think it's free download. So we've got to really understand regeneration to actually sort of really see what we have. If we look at the site, yes, it's got nice volume, but it was actually still soft after nearly 2 years, with particles in between. So what we really want to do is by getting the material to turn over the bone, that's the effect, essentially our aim. And when I look at this here, we can see in our study, which was published a few years ago using similar material, orthopedic material, in a 12 rabbit study. So as the graft area goes down, the osteoid area increases. So this is fulfilling basically our essential aims that we set out to do, is to replace the graft material with bone. And especially in the sinus, that's a good idea. So when we look at sinus augmentation with EthOss or a resorbable synthetic, essentially, the biocompatibility is nice. No pain the next day, lateral windows, internals, nothing. Patients always phone up saying that they never needed a painkiller. Bacteriostatic, great thing. The material's not going to become affected by the infection in the sinus. That osteoinductive potential I was talking about, yes, the study I published in Paris, we were placing them implants with as little as 3 millimeters residual bone, and we were loading them all at 8 weeks, helped by this osteoinductive potential. You don't have to wait 6 months. This is not the time scale of host healing. For example, if you break a leg skiing, fortunately, the doctors don't say, "Oh, I'm sorry, my friend, we're going to put some bovine bone there to fix the gap up and wrap it in a pigskin, and you can just lie here for 6 months." No, host biology and host physiology works on a much faster scale. So essentially, we've just got to allow their body to heal and work with this healing. So the idea of only host bone, so if we have a fully bioabsorbed material, so every time I look at an x-ray in 5 years or in 10 years at that sinus, all I'm seeing is the patient's own bone. I'm not seeing some HA or some bovine HA. Sure, if I want a good x-ray, I can throw a handful of HA and it'll make the x-ray look amazing. But that's not what we want to do. And I think patients prefer it, especially when you're working in a sinus, the notion of actually using something that's going to just resorb and become the building blocks of their own bone. That tends to make sense to the average patient. Right, for the last 8 years or so, initially, yes, I did it the same way as everyone else. I used piezo, or I used a round burn. I made a little window and I tapped through and we lifted, which was great. And it was fun because I always sat at the edge of my chair. But I like the idea of the DASC. There's a lot of other systems now. There's CASC. I'm sure most implant systems have their own way of doing it. But in lateral windows, in 8 years, nearly 8 years of using the DASC, and I use it generally once a week, sometimes twice, I think I've had 3 tears of a lining, and I've only had to abort one of them. So it shows that this has really dramatically improved the situation using the hydraulic lift of these systems. And that's just a poster I published at the EAO in Paris. And again, we were using Ostel readings to define the success. All the cases were loaded at 8 weeks, and all have been successful now. So that's about 4 years on since it was initially done. So yeah, I'm just going to show some videos, and we'll get an idea. Here's a difficult case, but this is using DASC. Okay, this is real time, and that's it. We're in. Okay, so that was real time. That's how long it takes. So, and as you can see, it's already partially helped us lift the lining away. You know, the one case that I had to abort, I just touched it with an instrument, and it was like a soap bubble, and it was gone. So as you can see, there is, in this one, there's an oriental communication on the site easily, so it was making it a little more difficult. But this is just going through and just showing you, you know, everyone's got their own lining instruments. I remember when I first started my very first sinus, I think Barry just got a Mitchell's trimmer from the drawer, bent it, and said, there you go, that's your, and I used that for about 8 years. It was amazing. So as you can see now, when the patient's breathing, the sinus has been more lifted, and we can lift it further. You can see, well, when we're actually now placing the implants and grafting, you can see there where the oroantral communication was mesally as well. So we're going to place the implants, graft into the site first to get the graft material to the mesial wall, and then we just graft the buccal wall and seal the window with graft. Okay, so, and there the cases. Right, now we just go on to another one, and I'll show you how I mean by placing the graft material in such. I've already lifted this, you can see it by opening. And then what I use is the DASC internal, and as you can see, again, it's using hydraulics. If you look at the lateral window now, you can see saline is coming out the lateral window. Then what I'm doing is, this is essentially grafting, so the graft material gets to the mesial wall. Then we place the implant, and then seal the lateral window with the EthOss and get the nurse to hold with a dry gauze. And this was part of the study I did for the Paris research. So you can see loaded at 8 weeks. It gave 75 ISQ at 8 weeks, so that was fine. And it's been loaded about 4 years now, this case. And there it is, loaded 9 months. And again, you can see what I mean by the material turning over and becoming patient's own bone. And here's a scan taken 2 years later. 2 years later, and you can see how the lateral window is sealed, and we've got really good new dense bone around the implant in the sinus where we've grafted. This is because, I'll show you later, we had to remove, I'll show it in another case. In fact, here it is here. This is the other side of the same patient, and you can see there's a root was pushed in by the dentist. So we had to remove the root. Normally you can actually remove the root through a lateral window and graft at the same time, but this case I decided to let it heal, and you can see in this, the scan pictures underneath how it healed. And then we just did another small lateral window, placed the implant. As you can see, we're trying to regenerate a little bit vertically as well to get a flatter platform. So you can see when the implant's placed with the graft material, we're hoping at getting an improved platform, which I'll show you in a minute. And here it is, loaded a year. And again, you can see how, because the material is turning over to host bone, what I assess is actually host bone. Do I need to use a 16? Yeah, we used to use 14, 16 millimeter implants in the sinus years when I first started. But a lot of the research shows us that the top end of the implant is just sleeping in there anyway. So there's no need to fill the sinus up. You know, it just creates problems. I've had people putting in you know, 3 syringes of some material at times, and it's literally blocked the ostium, and then they have to go to the ENT to have it all removed out. So, you know, just what we need is, and we've now understood that shorter implants seem to work effectively. And here's a sort of a case where you can see the vast majority due to perio is being lost by the vertical height's being lost. So when I'm actually grafting the sinus, I'm not grafting, I'm putting a 12mm implant in here, I think, and I'm grafting laterally, but I've only put a small amount of bone in. But what we're also doing is we're grafting and we're growing the implant vertically so that we can end up with a better restoration platform. And again, I think the next case will show the same. And this is a good thing about using these materials, is that we're not just using them in the sinus, we're also using the same material. Often I get 1 cc and I split some and put some in a dappen dish, so I use some in the sinus, and then the next little bit I actually then mix with saline afterwards, and I can restore a vertical height, and I can actually restore buccal defects. So I'm only using 1 syringe of material to do all of these jobs, and that's the great thing about the materials, is that it allows us to do multi jobs. I don't have to open up 5 boxes and different things and put them in. You know, I do 99% of all my grafting with the same material and same principles. And here's another difficult case where we're going to do a lateral window, because this root was in such a situation that I was fearful of it being pushed, and it was referred to me like that. So I did a lateral window, pushed the root from inside back out, then placed the implant, grafted, and as you can see all the new bone regenerated in the sinus at loading. And again, it all looks great. And here is the actual clinical photograph. You can see the lateral sinus, you can see the palatal root, and you can see where we've pushed the distobuccal root out. That's the osteotomy side in between the palatal root and the distobuccal root. And again, here's placing the implant into the site and grafting. As you can see, we're going to fix the buccal defect up at the same time, plus seal the window. I will show you, when people say you need a membrane over the window, no, the membrane is actually going to stop the healing. You've got the periosteum, you've got a stable graft material, it's got osteoendotrophic potential. That window will be healed over in 8 to 10 weeks, and I'll show you one at 8 weeks in a minute. Anyway, there's a picture of the root at the bottom as well at the end. So again, you can see, you know, this is a sort of a routine process. You can see there again, we're using DAS straight through, lifting, placing, grafting so that we get the graft to the mesial wall, placing the implant, and then sealing the window. There it is again. Yeah, I probably should have put a little more graft on the buccal surface here to try and improve the profile of the bone. But again, it's an upper 6. It's not that critical, because as you can see, we've probably made a nicer result. We could have got slightly fuller buccal profile, but it's fine and it's worked well. You know, you always look at cases and you say, I wish I'd done that afterwards, when you're looking at the photographs, and that's the easy part. Right, here's just showing this whole principle of multiple jobs being done. Here's the beginning. Okay, we've got this case. Lady's come in, she's got a mobile 5. So the tooth behind is mobile, probably grade 2, and she's lost this tooth periodontally. It was taken out about 5 weeks ago before it came in here. But what you can see as well is we've got no keratinized hard tissue, we've got a frenal pull, and when you look at the x-ray, you'll see we've got a sinus issue. So what we're going to do is we're actually going to do this. We're going to allow the material and the benefits of working with host healing. You know, people sort of say, oh, that's amazing. They say, no, it's not. That's just what the body does. The body wants to heal. It's just us learning how to understand that if we chop things up more, the bigger flaps we make, the more materials we put in, the less the body has the ability to heal. We want to actually keep surgery minimal, and they really understand this in medicine now. The whole idea of reduced surgery is becoming a really important thing. I know, just had a whole lot of surgery myself on my neck, and I'm amazed how if you try and keep the amount of cutting, and it heals so much better, because the more cutting you do, the bigger the flap, the more you're disrupting the blood supply to the site that needs to heal. So these are important things I think we need to sort of start helping work in that area. Anyway, you can see there's a buccal defect here. You can see I've done a lateral window with the DASC again, and I'm cleaning the root of the distal tooth to try and regenerate bone up against that. That's another whole lecture, and you know, instead of doing all on 4, what I do is take out the worst teeth and then basically put implants and graft in those sites, and it helps stabilize the teeth that are not that bad. So in actually, you can take reasonably poor perio cases and keep all that hard and soft tissue. So you know what, they stay a little younger than just taking everything out. The moment everything goes, we lose the profile, we lose the shape. Anyway, so here it is. So as you can see, all we've done is not overgraft. Can you see anything that's gone way above? Yes, if you want to build buccally, that's a different matter. I can show you doing that, but we're talking today on sinuses. And here it is at 9 weeks being restored. And as you can see, we've already effectively got a nice sort of keratinized tissue. I've done no soft tissue grafting, just use an incision and push buccally a little bit, but the host will help regenerate that more, and we've now got stability on the tooth behind. Here's the x-ray showing the issues. You can see the perio on the 4 that was removed, and the sinus, and that's just grafting and buccally and working on. And here it is at 9 months, and as you can see, it's an adequate outcome, and we've got stability of the upper 5 now as well. Yeah, the tooth's probably a little white, exacerbated by the flash, I guess. So again, this I just did the other day, and you can see the principle here. I packed the implant, the graft material in, and when you're screwing the implant, you can literally see the graft material pushing out into the sinus and pushing buccally. And again, this just shows the principle. You see the implant in front with a little buccal defect. Yes, I'm going to repair that at the same time with the same actual tube of material. I've just split it into 2 halves. Half I'm putting in with the syringe, and half I've mixed the first half in a Daffin dish and used an amalgam syringe to place that into the osteotomy. Okay. So this is the whole concept of trying to actually get a flat platform. You know what, when you lose the bone in the posterior mandible, posterior maxilla, what often happens, it proves to be a really difficult thing to restore, because you've suddenly got your first molar or where the site is, and it's a bigger tooth because we haven't got a flat platform. So what I often do here is, like I've done in this case, you can see I placed the implant, grafted in the sinus, but I haven't placed the implant all the way in. So I've left it 2 millimeters out, and you can see the graft on the slide down on the lower left. You can see where it's grafted there to get a vertical flat platform. Okay, then the patient was in 18 months later, nearly 2 years, for a re-cement. I don't know why we just cemented this molar. I normally screw retain. And you can see what we have now is a vertical growth of a few millimeters, and you can see the bone in the sinus is turned over to fully host bone. So this allows me to do that assessment long-term a lot easier, because I haven't got foreign material there, which is clouding my ability to assess the x-ray. And again, we'll just do another one, just showing you literally, again, this is real time, and you can see we've got a defect in the front as well, so we're going to graft that. In this case, the patient only wanted 1 implant initially, but we're thinking about, oh, maybe I'll come back in 2 years. Because of that, yes, the bone could remodel the new host bone, so I decided here to add a bit of HA. But that shows you, this is a nice thick buccal wall, and this is real time. This is no editing. That's it. There you go. We're ready to roll. Party's on the go. So, and again, this simplicity, just be a little careful often when you're lifting. Always remember to look for septa. Try and get the understanding of the floor of the sinus, you know, with your instruments. You can always feel if there's sharp ridges or if there's septa. You know, try and actually not try to lift too hard over those particular areas, because those areas could be the area you will end up having a tear. So you can see we're going all the way around, going down here as well. So you can see when you look into the cavity, there it is there. You can see it's closing and opening as the patient is breathing. So that's, and then as I said, in this particular case, we're doing the internal gain. Now you can see the saline coming out of the lateral window. And, you know, that's just helping us make the whole procedure safer. Now, because this one, I'm actually going to pack all the way in, and I've added some HA in this particular. You can see some of the white particles. I've got EthOss, and here's just standard EthOss being used and to restore the buccal. Okay, so we're going to just place it on. Yeah, I cleaned that little bit of granulation tissue away, and there it is. So we're going to restore the buccal with a really nice dry mix of EthOss. To make EthOss dry, take it out and add the bare, take it out of the syringe and mix it into a Dappen dish and add the bare amount of saline that's needed. Here's the case. You can see there's the before, that's at grafting. And if we look at it, that's placed on the implant, that's grafting, and that's getting ready to load the last X-ray. There it is being loaded. There it is loaded. Here it is loaded, and you can see we've got HA in there, so we've still got enough bone. A year and a bit later, when she came in and decided she now wanted the others, gave us an opportunity to take a core. As I said, we always like to see what we have. And the interesting thing here was because of the HA, it gave us it showed the difference between HA and the beta-TCP and the difference in the cellular activity around, which is something I can show you on later material we have. Anyway, here we've restored both. Yeah, it's another 9 months, so you can see, and that's 3 years loaded. Everything seems fine. 76 on Ostel. So now let's actually look at internal crestal approaches. Sometimes people think that this is easier. Yes, it could be seen as easier, but sometimes you may get little tears, and you can never really tell 100%. Even I just put a video up and I'll show you. There might be tear. I didn't think there was, but you can never really tell. Here you can see a nice picture of the lining underneath, and you can see how it's being lifted away by the hydraulic pressure. And that's the key, is that the hydraulic pressure of the saline onto the lining has lifted and makes it a little easier to lift and to actually move. If it's really very, very tight, always have a lot of caution, because internal lifts, just some cases, they have very thin lining and it can be very tight. So that's the difficulty. And here's just showing the implant we're going to place, and that's showing the internal disc. You can see the saline. I sometimes don't use them, but in this particular case, I'm showing it because it's important. We've got these little sleeves. It's like having little side wheels for your bike to learn how to ride the bike. It just helps you not pushing through too quickly when you're getting through. But as you do more and more and more of them, you can feel exactly when you're going to go through by feel. So, but it's just safer. And again, here's using an amalgam gum to place the graft, and as you can see, it's an effective way. So I mix the saline, mix it slightly wet, and mix in a dampened dish, place the graft, and then we can place the implant into the site. So now we've got a peri-implant defect as well, you can see. So we're going to regenerate this as well, and you can see now we've got EthOss covered around the site. And then at 10 weeks, you can see we've raised a flap now, because new host bone has overgrown the implant, as you can see. So we need a round burr to access the implant. This case is being done by a referring dentist, so I've got to actually do this, put a healing cap on, send it all out. I actually must get some photographs from him. But you can see how the peri-implant site now is fully regenerated with new host bone, and we've got an adequate outcome to the case. Again, this is just from yesterday or the day before, and again, just showing sort of video footage of it. This was actually a redo. I'd done it already, and I just put more saline in. There's probably some air in there as well. As you can see, there were some bubbles, and then this was the dispute where the bubbles, a tear. There was absolutely no, as far as I could see. Anyway, with these materials, if there is a small tear, again, it doesn't matter that much, because the material is abacteriostatic, and B, it's stable. So even once you've placed it in, it stays together. I've taken it to extremes where I've taken implants out of sinuses and grafted directly through the lateral window, destroyed all the sinus lining with a Mitchell's tremor or something, or an elevation instrument around the side of implant, grafted directly through the lateral window. In other words, just straight into the sinus. And all 20 of those cases we've done over the years have all been successful, because the lining is ciliated epithelium and it just heals back over the side. So it's no problem as long as the graft material is stable. That's all we need. So here's just showing the case. You can see I was going to try and angle it, and I'm not a big fan of angling if I can put it straight and lift the sinus. And the final one just shows the x-ray of that case. And again, the benefits, as I said, are we can actually restore buccal defects at the same time and graft everything. Here's just suturing with PTFE. So, you know, we often do this. Can you see we've now got a big buccal defect and loss of volume and loss of height, and you know, and that's where we restored it to, back to there again. So when we look at it, there's the case. Take the granulation tissue out, degranulate the site. You can see the implant. There's the sinus lining. So what we're going to do is we're just going to graft into the sinus, push the implant, screw the implant, lifting the lining and with graft material. There it is there, and we're going to just graft the buccal defect, the small defect. And there it is there, taking pickup and loading, and when you're loaded, you can see the x-ray. We now have full bone everywhere, and we've restored, you know, the vertical dimensions and the buccal defect, and we've done it all essentially in one surgery. Patients like one surgery, believe it or not. They always prefer to have one than two. Here's showing the whole case, showing loading and loaded at a year, and you can see how the material is turning over from graft material to host bone. You can literally see the quality. When you look closely at the x-rays, you can see this turnover, and this is the important aspect. And so when we're doing the same here with an internal and buccal defects, mesobuccal, distobuccal, palatal root, you can see we've got a few millimeters. We've done an internal lift. I'm not going to put the implant all the way in because I want to grow the bone back up so we've got a nicer, flatter surface to get a better restoration. And then we graft it. Not too much graft. I'm not over grafting. You know, the whole concept of, oh, we put a whole lot in so it goes away, that doesn't work when we're actually regenerating. Regeneration requires the periosteum to be close to the site, and it'll actually expand, so the volume that you put in will stay there or grow to more, rather than, oh, we expect to lose X. No, that's not the principles we work on, so don't overgraft. Here it is loaded at 9 months, so you can see it's an adequate outcome. And the interesting thing, I was going to do the opposite side, and it was a big septus, so I decided to get a scan. In the UK, you have to have a reason to do a scan. You can't just do a scan to just see how cool your work is looking, because that's no benefit to the patient. And there could be medical legal ramifications. And here, when we look at it at 9 months, you can see where the palatal root and the buccal root. You can see we've got new bone. You can see the new bone regenerated into where the sinus was augmented using the internal lift. And again, when we look at it on x-ray, you can see that's at mid implant depth, and at the apical tip, you can see that looks fantastic, and there's a little bit of new bone on the buccal on the scan. Yes, xenografts work well. This is placed 18 years ago, this xenograft. The case looked really good, but when you look at the scan, is it new bone? Is it patient bone? Yes, it's working, but are we're definitely not regenerating. We're augmenting, or we're integrating foreign material, that's all. So, and it stays there forever, according to Albrechtsen. And yes, according to this research by Michael Norton, I've never used it in sinus. He's experienced the problem really when you don't have the patient's own bone. Bone is living material which turns over consistently. Our whole skeleton turns over fully, I think, twice in our lives. The problem with putting foreign material, it can impede this turnover and lead to sort of a sclerotic situation. So in other words, the bone dies. When we take cores at 10 or 12 years of sites, grafted with these materials, we see no osteocytes. It's because the bone generally is dead. Yes, it's hard. Yes, it's probably holding an implant well. But we've got to get it into our minds that, in actual fact, we're dealing with living tissue. We've got to look at it this way. I like this osteoidentification. My good friend Ziv's coming. I've just started doing it. This was a case done by a friend of mine with EthOss. So again, you can see you could try and support the tooth behind by regenerating. This would be an interesting case. I've done a few cases myself now. I'm always someone who likes to see how something goes over a few years, but I like this. This seems to be a good idea. Again, it's minimally invasive. I like the concepts, and it will work very well with what we're doing and the concepts and the materials. Sure, this is just a quick pictures where we don't want to be. I just removed this the other day for someone, so we just nice to show that. And if we look at regeneration, this is just an implant, and we're showing us over a period of time. That's the root fracture. That's grafted, the second one on the top. Third one is at 10 weeks, loading. Fourth one on the bottom is loaded 6 months to 1 year, and the other's loaded 4 years. Can you notice how the regenerative effect? There's none of this nonsense like the old days when implant systems have changed, platform switchings around. There's no hard and fast that once we place the implant that we're going to lose 0.5 millimeter in the first year and 3 millimeters in the next year. No, this contradicts that, and this is where we're working today, not there. We're just looking at a simple case again with a socket graft, sealed over. Then we go open it at 12 weeks, re-entry, and here we're taking biopsy. And again, you can see the lining down underneath. So we're going to just put graft in, place the implant, push the lining up, and then we're going to we took a core sample of that socket graft, and this is histomorphometry. Again, this is done in Germany at Freiburg University, and so you can see at 10 weeks, 12 weeks, there's only 8% residual graft material, whereas taken right from the middle, we've got 48%. We've got other research. Just look on PubMed, you'll see case studies we've done with others. And this is the interesting thing when we look at the new bone and how there's a lot of cellular activity and how the new bone is literally growing into the particle of EthOss, and it turns that particle over to host bone. I've got another picture later on, and here's just showing the rest of the case. Again, looks great. And this is why it's quite nice, because when we compare this to a bovine bone study done by the same people, same histologist, and we look in the bottom, you can see all the bovine bone and that small amount of new bone in the bracket. Is this necessarily what we want? So when we look at it histomorphometrically, the top is the EthOss, and you can see the new bone is red, EthOss particles blue. You can see quite a nice percentage of new host bone. Whereas if you look at the lower one, the green is the xenograft, and the red is the new bone. So yes, it makes a great picture or an X-ray, but the amount of new bone is reduced. And so finally, I'll just show you this actually is an Australian patient. I think that's the second last case, and you can see we've got a little defect there. He lost an implant. I think he had it done in Thailand, and we've just grafted it. And there it is at 10 weeks. You can see the nice thing is to know that you've got host bone, and this gives us a much better situation. And this is just different histology. This is great von Giesens, Harry Prasad, Minnesota. Again, all of these studies showing the same thing of what we're seeing. And the benefits, again, of placing in the sinus, if you look at this case, there's only 3 millimeters, poor residual bone. Don't have to graft that much into the sinus, because we can also be regenerating the bone up, and you can look and see exactly what's happened in that final case. The final X-ray is 4 years, and here it is loaded at 4 years. So we've managed to get a nice platform. This molar doesn't look halfway up, because not only are we growing into the sinus, we're also growing the bone, restoring the bone vertically, and this gives us a better outcome in the long term. Finally, I'm going to just talk about using materials. You can use them in infected cases. Here you can see this case was sent to me by the university, by the hospital, to place an implant. As you can see, we had a little problem or two, a couple of communications. It was suppurating. So you can see there I've got a lateral window. you can see where there's an attachment once I've used the DAS. So we just severed that with a scalpel. There's another orantual measly, and then as I was lifting it, suppuration was coming out of here. This is orantual communication on the top. So I just lifted it as much as I could, go as much of the part, and then just grafted it with EthOss. There, graft the lateral window. And this basically is that patient at 8 weeks. So this is 8 weeks after I did the lateral window. You can see where the lateral window is now. Can you see it's completely sealed? It's completely healed. And where we had the orantual communication, it is now healed at 8 weeks. And this is using host healing. You know, this is not waiting 6 months or doing 9 months or waiting, oh, because, you know, we can wait. Well, why wait? It's not a question of rushing things for the patient. It's that this is the way the body heals. This is host healing. All we're doing is optimizing the host healing. And it's done then, you know, they're taking the roots out of the palate. And there you can see in the final one, you can see the new bone that the host has regenerated exactly at the same spot. And so we've sealed the lateral communications, we sealed our orantual. Yes, there's still a little bit of issue in the sinus, but it's clearing up. It can take quite a long time for the cilia to clear out. I could get an ENT to scope through the ostium and remove it for us, but patients had no symptoms, and it's been loaded for 4 years now. One final little thing about placing into infected sites. This is doing an apicectomy in the case. This tooth was grade 3 mobile, massive pockets. You could put a probe all the way down measly and buccally. And as you can see, the healing of using a graft. Do we need grafts when we're doing? Probably not. Does it help? Yeah, I think we like to think so. And here you can see by probing now, it's somehow restored the buccal and the attachment of the mucosa. Right, so this is the final slide. So we've run it exactly for an hour, which is great. And this is really the epitome is done by my partner here and my research partner, Minas Avensis. And, you know, do we really, if we want a great picture, yes, HA is fantastic. It just makes everything look white and look great. So, but I sort of feel we want the true picture. And the only way to get the true picture is to use materials that bioabsorb. Yeah, you know, sometimes when we're building up or we're augmenting and building out, sometimes, yeah, we might need a few bricks. So yes, in those cases, I have been known to throw some HA in because it helps hold against the forces of musculature and of the tissue. But generally, in 95, 99% of my cases, I prefer to just have the patient's own bone. And this is what we like to sort of say is the patient, when they come to see me, they say, Doc, can you heal me? Can you fix me? That means returning them back to the state they were before, not necessarily changing them or their species, you know, into something else. And that's why I prefer, you know, looking at things in this sort of conceptual idea. Right, thank you, W9, and for all the delegates. Let me see, did I have my, yeah. There's my email address at the bottom. If anyone wants to contact me, or they can contact through our agents. And if you've got any ideas or any difficulties, because, you know, it is actually working a different way in regenerative dentistry, and we just need to understand that. And it does require slightly more fine skills. Look, I've got a couple of friends and Max Fax guys, they're never going to understand regeneration this way. It's always going to be a different way, you know. So that's great. Lots of things work in dentistry, and it just helps. It's just an understanding of working with healing. Thank you very much, and we'll just go back to the hosts now, to our host, yep. W8, and we get some questions. All right. Thanks a lot. Thanks a lot, Aaron.
Peter, can you hear me?
Yeah, sure, can hear you.
Excellent. Thank you for the presentation. And we've had a number of really interesting questions from the attendees.
Yeah, sure.
I've got a number here, and I'll try and keep it short, but here we go. So the first one was, how do you prevent fibrous encapsulation of your implants without a membrane?
Yeah, you see, this is the question I always get asked, and I'm glad it's the first one. You know, the whole idea is, when you're using a xenograft, these ideas about the soft tissue growing in were basically set up by a couple of guys in Switzerland There's no research, there's no backup to say that the soft tissue grows and it doesn't. Fibrous encapsulation is because xenografts are detected by the host and elicit a giant cell reaction. And that giant cell reaction leads to this encapsulation. It's the host trying to protect from a foreign body. As these materials are highly biocompatible, it doesn't seem to be an issue. Also, site cleaning is important, and stability. Stability creates bone. And here we have stability by the shape of the particles and the calcium sulfate, which bioabsorbs at 3 to 4 weeks, and it leads to a further vascular ingrowth, so optimized bone regeneration. But I think I've seen some granulation on the surface areas in probably about 4 or 5 out of 1,500 grafts using EthOss. So it can happen, but it generally happens when there's been a spontaneous exposure or an opening. But I haven't used a membrane in my last 5,500 grafts, and it seems to work better without. As far as I can see, yes, if you're augmenting and building up, you might need something rigid. But as I showed you at the beginning, we're looking at different techniques to overcome that and still be able to use the periosteum.
Thank you. The next question was, does two-stage or single-stage surgery have different success rates with EthOss and your grafting technique?
I probably only two-stage, 1 in 100, or maybe 2 in 100. The idea is always to one stage now. I know when I started out doing them 20 years ago, it was like, or 25 years ago, sinus augmentation was heresy to say that. And I remember people used to criticize because I used to always just one stage them. And I had dinner with Hill Tatum once, and he said, no, it makes sense. Why do you want 2 operations if you can have 1? So, although that's the way it was invented or decided, but by putting in one stage, you're placing the implant, and the implant is a semiconductor. And the implant itself, if you look at the research by Sasaki, 2013, and Jomi, it shows you that by just placing an implant, you upregulate the host response to bone metabolism. And then by loading earlier, you get a secondary spike. So I very rarely two-stage.
Thank you. The next one is, does the vertical bone growth help with papilla regeneration?
Yeah, because obviously the conceptual idea is that the only thing that's going to hold the papilla is the bone. And I've got other cases in the other lecture where I can show you the dramatic effect it has over a period of time, especially because what we see is we seem to see with time we get more vertical growth with these materials, and we're not sure why, but everyone's seeing it who we're working with. And we're not sure. We need to do more research as to why it continues and why the effects. And again, it might be the potential. So when we load the implant, we generally at the end of the first, you see 1 millimeter vertical growth of the new host bone. Yeah, and if growing up against the tooth next door, yes, that'll help with papillae growth. Yeah, between 2 or 3 implants, it's always a little more difficult thing.
Cool, thank you. Could you please elaborate on how to stabilize EthOss graft, i.e. with sutures?
With sutures, yeah, that's a whole technique and another thing. Look, those are 2.0 TDS. They like resorbable sutures, quite thick. What you do is just drill little pinholes with a green stable arc drill, cut a small section of the suture, and then you just push the ends in so that it forms like, and all that does is it forms a trampoline. There's a whole lot by Mike Ainsworth on that. Again, I think we've got some on the website. If not, I'll make sure that gets put up so it can be explained.
Cool. We'll get a list of the questions, and the people who have asked it, we'll try to get the answers through to you in an email as well.
Yeah.
Another one is, what is the name of the instrument used for the sinus membrane lift, and do you use the disc for entrance for the sinus with a slow speed or a piezo?
I don't use piezo anymore. I'm too old. My life's too short. I've only got a little bit left of it, so I have to. I find that I know the new piezos are great. I'm a great friend of Angelo Trottam, who's the expert in the world on piezo and sinuses. He's published a lot, and I'd say that they're great, and I did use them. But these new discs, instruments and now with Versa, I think, you know, things can be done a lot quicker and safer, and we don't seem to have problems with them. I mean, all the companies have got their own, and they're all a variation. But it's such a big help to us. I mean, I've been doing this for a long time. When it was difficult, my first starting, it's massive help, these protocols and tools.
Yeah. Thank you. I've got another one. I'll probably do two more. If there's any that I've left over, they're quite long.
Yeah, we can just do them by email. Yeah.
Yeah. I've just got one more here, and then anybody else who I've missed, my apologies, because we are a little bit strapped for time. But we will send them off to EthOss and we'll get the answers. So I did quite like this one. It was they wanted to know if you know your rate of graft failure over your extensive period of using the material, and do you know why the grafting cases would have failed, and what was your response or your protocol to resolving it?
Oddly enough, the grafts don't fail. You can lose graft if you don't surgically get the basics right, and especially on the uppers, if you're just placing in without suturing correctly or into a socket. That seems to be the biggest thing, is graft loss. Grafts don't really fail. I mean, it's hard to sort of say. I mean, I don't sort of see it. You know, as I say, I've done about 1,500 with EthOss, probably more now, about 1,800, and I've had to regraft 8. So it seems to be quite good. The main reasons for any not formation of bone are all down to sort of surgical and not seeing muscular pull, and so it's quite a complex area. If you're putting it into a sort of 3-wall defect, I mean, it seems to just work all the time. We never go in and sometimes physiology varies in patients. Some patients might take a little longer, because, you know, we are working at 10 weeks. So, you know, the best thing is to be a little safer, go 12 weeks. And you can see the effects by those push-ins. Like, for example, push-in with no primary and no bone to implant contact. I've done 130 and we've had 1 failure, and that was due to infection. And I just took the implant out and we placed the new implant into solid bone 2 months later. I mean, I could show that case as well, but we're surprised. We're quite heartened by it. As I say, we've only been using the materials and the techniques for 16 years, so it's not long term as yet. But we seem happy with things. It's generally there's some surgical aspect for failure. Cleaning the site is the big issue. You know, we use degranulation burrs. I know you don't have them in Australia, but for me they're very helpful. Anyway, yeah, let's go on to the next one.
Okay, last but not least, and there's a few more that I've missed, and my apologies. In the first case, you put into the implant, in the socket it was filled with the graft. Was there any pathology that you had scooped out? Basically, I tried to say that you can put your graft in the socket where there was a bit of infection.
No, this is the key to everything, is in that particular case, it was allowed to heal for 3 weeks, then a flap was raised. And so it was covered with a very frail flap. But the reason I don't graft immediately at extraction is you can't clean the site that effectively. And that's where the problems start. So we've developed a sort of socket protocol where it's delayed healing and then open it. And when you've got a flap, it allows you to look at the site and really clean the site. A lot of graft failure in socket grafting is you're just basically putting the graft onto an infected site, and guess what? It all comes out. I mean, or there's a problem where it gets infected. Yeah, that's really important. Is site preparation is very important, and making sure things are clean. When you see degranulation burrs, you'll see they're quite effective. They're basically just a round diamond, but running at a slow speed with irrigation. So yeah, that's a big thing. All right. So I think that's probably best if I say thank you and goodbye to everyone in Australia. Have a beer for me, because I've got to go and start doing an implant case now. So have a beer for me, and we can do everything by mail. Okay, by email. All right. Thanks a lot.
Thanks, Peter. Thank you, attendees. If you have any questions, please email Peter or myself. My email address is noah.schroot@w9.com.au. That should have come through on the email on the webinar. And once again, thank you all for attending. Have a good evening. Goodbye.